Hello everyone, you're welcome to today's discussion class. And today we're going to be looking at um, pharmacology, okay, which is a different course altogether from the ones we've been having the previous weeks on microbiology. So it's a different course altogether, and we're going to be discussing everything about pharmacology that's in relation to drugs and its components, especially as it relates to public health. All right, so we're going to be going through every component of pharmacology, pharmacokinetics, dynamics, and everything in between. So as we progress, we're going to be seeing the different modules and units we're going to be discussing on this course. And as you know, we're making use of the outline from the um, pharmacology course, PHS 810 from the National Open University of Nigeria. Okay, so my name is Jane Nnenna Ezikeanyi, a master student of the National Open University. So this should not be a substitution for facilitation or any material that's been provided from the school. So this discussion is majorly done to enhance learning and then more understanding of the course. All right. So let's dive in immediately to the class discussion. So today we're going to be looking at the module one, which is the basic principles of pharmacology. Okay, so under the module one, we have different units, 3 units. We have the basic principles of pharmacokinetics. We have the unit two, which is toxicology and adverse drug reaction, and then drug discovery, development, toxicity, and then phytomedicine. So for today, we're going to be looking at the unit one, which is the basic principles of pharmacokinetics. All right. So I just want to make it clear at any point you understand or you have question, okay, you can just drop it on the comments. I will try as much as possible to attend to it. Okay. So let's look at some of the definition of the common terms we're going to be seeing as this course unfolds. Number one is pharmacology, which is the general course we're discussing. What is pharmacology? It's a scientific study of the origin, nature, chemistry, effects, and uses of drugs. So it deals with how drugs interact with the biological system to affect a function, which the aim is just to effect a therapeutic if function. All right. So pharmacology is discussing of everything about drugs, just from the name pharm. So it's discussing everything about drugs, how drug is being produced, what it contains, the makeup, the sources, how it actually interacts with the body, how it produces an effect or efficacy, or even toxins, all right? So pharmacology is a general study of drugs. Okay. So what is a drug? Drug is any substance or product that is produced, that is used or intended to be used to modify or explore physiological system or pathological state for the benefit of the recipient. So this definition is according to WHO in 1996. It's just trying to explain that drug is anything that is being used to elicit a therapeutic effect that is used maybe to heal a disease, to reduce the intents of an illness or infection, okay, for the benefit of anyone that's actually taking the drugs. Okay, so what is toxicology? It's the science of poisons, the sources, chemical composition, action, taste for the detection and antidotes. So just from the name, toxicology, study of toxins, okay? So you have to know that all drugs are potential poisons when given in higher doses. So what is clinical toxicology? It deals with the detection, diagnosis, and treatment of poisoning. Okay, so let's look at pharmacotherapeutics. It's a study of how drugs may be used in treatment of disease. That's talking of those that's the most appropriate drug to use. Okay, that's the use of drug to heal or to cure a particular disease is what is called pharmacotherapeutics. Then what is pharmacogenetics? It's a study of genetically determined reactions of drug in the human body. Then what about pharmacokinetics? is the study of drug absorption, distribution, metabolism, and excretion, bracket ADME. That's what the body does to the drug. These drugs are being taken into the body, and there are a lot of reactions that the body exhibits. Okay, so pharmacokinetics is discussing what the body does to the drug. Okay, it just like an opposite of what pharmacodynamics, which is the study of what the drug does to the body. Okay, so it's the study of the biochemical and physiological effect of drugs as well as the mechanism of action. Okay, so it's opposite of pharmacokinetics, which is what the body does to the drug. But pharmacodynamics is what the drug does to the body. How does it actually elicit this action to heal or to produce a therapeutic effect? So let's look at the nature and sources of drugs. There are different ways that drugs can be made or the drugs can be produced. So we have plant sources. So plant important source of chemical developed into drugs, like example, digitalis, morphine, atropine, quinine, and some vitamins. We also have animal sources of drugs, like from cow and pig pancreas issues, from thyroid drugs, that is from thyroxine, and then growth hormones. We also have mineral sources, then from microorganisms, like one of penicillin and other antibiotics. We also have streptomycin from the microorganisms. All right, we also have synthetic drugs and then the bioengineered, that's recombinant DNA technology drugs, like the human insulin and then the human hormone. Okay, so these are the different sources of drugs. Then let's look at the pharmacokinetic processes, which is our key topic of today. Okay, so what is pharmacokinetic? Is a tool for describing the movement of drug during the body over time and deals with the processes of absorption from the site of administration, distribution throughout the body, metabolism or conjugation of the drug, and then elimination from the body. Okay, so pharmacokinetic is just discussing how the drug enter the body, how it actually how it's absorbed, how it's being distributed to the target site, and then the metabolism of the drug, and then elimination of the drug, how these drugs are being removed from the body. That's what pharmacokinetics is talking about. So why do we study pharmacokinetic? Number one, it's essential for individualized optimal use of drug. For example, choice of drug, then the route of administration. Different drugs require different routes of administration for the specific purposes, all right? It is also essential for determining dosing regimen, that is the dose of drug to be taken at a particular time or at what frequency you should be taking these drugs. Below is a threshold concentration. So the drug is inactive, and above a certain concentration, side effects appear, which is called the toxic effect. Therefore, the dose should be aimed to remain within the therapeutic window. So this is just telling us that as if a drug is being administered um less than the therapeutic, like less than the amount is going to give this therapeutic effect, it means that the drug will be inactive or it will not elicit its efficacy. But if the drug is given in a higher doses, more than required, it's going to exhibit what's called a toxic effect. But drug should be aimed to be within a therapeutic window, which is a kind of a normal range that the drug should be given, so that it will be safe, number one, and it will not produce a toxic effect. All right, so that's what this is talking about. We have 4 pharmacokinetic processes, and that's what we're going to be concentrating on. We have absorption, okay, distribution, metabolism, and then elimination. So it has a short form of ADME, which represents absorption, distribution, metabolism, and then elimination. Okay, so let's look at drug absorption. Absorption is a process by which drug proceeds from the site of administration to the target site within the body. So it's an irreversible transfer processes which a drug moves from a site of administration to the systemic circulation. All right, it's necessary for the production of a therapeutic effect. If a drug is not absorbed in the body, it means that the body or that particular drug will not produce a therapeutic effect, or it will not cure that particular disease is being targeted to cure. All right. So we have different factors that can affect the movement of drug through membranes, because these drugs that are being absorbed in the body, they move um into the body, and they have to bypass a lot of cell membranes in the body. Okay, so factors that can affect movement of drug in the body, we have the route of administration, like we're going to be discussing the different routes of drug administration in the coming slides. We also have the physical chemical properties of the drug. We have the nature of the membrane. Is it a permeable membrane? Is it a membrane that easily allow things to pass through it, or the one that doesn't? The perfusion of the absorption site, and then the pH. We also have formulation of the drugs, in the sense that drug can take different forms. We have the ones that are made in tablets, we have capsules, we also have the ones that are made in solutions, all right, or even coated drugs. So there are different formulations, and this formulation will also affect the movement of the drugs, or how the drugs is being absorbed. So let's look at the route of drug administration. There's different routes, or different pathway, or different ways that drugs can actually enter the body. But one, we have oral administration. This oral is talking about taking drug through the mouth, okay? Because when you swallow a drug, or when you try to take the drug through the oral um, route. Then we also have parenteral administration. It includes intravenous, intramuscular, subcutaneous, intrathecal, inhalation, intranasal or sublingual, buccal or rectal routes. So all these fall under parenteral administration of drugs. All right. We also have different other modes. We have topical, like application of the drugs on the skin, inhalation, and ophthalmic. And we're going to be looking at them in details with their description, advantages, disadvantages, and then examples of drugs that can be taken into these different routes. We have oral administration, okay, where drug is swallowed and absorbed through the gastrointestinal tract. Advantage is that it's very easy and convenient. It is non-invasive, and it's cost effective, because it can easily be taken by anyone based on um, doctor's prescription. All right. So disadvantage is that slow onset, is subject to first pass metabolism, and is not for patients that are currently vomiting, because they have a high tendency of vomiting the drugs. Okay. And then it's subject to first pass metabolism. This is a very crucial thing about drug. Okay. It's a very crucial um activity that affects drug absorption. Okay, so it involves metabolism, especially in the liver cells, where some enzymes in the liver degrade the drug, and then it reduces the bioavailability of the drug. We're going to be discussing in detail as we progress. Okay, so examples of drug that can be taken orally: we have paracetamol, we have metformin, we have amoxicillin, and a lot of them. We have a lot of drugs that can be taken orally. So it's not subjected to only these ones that I've listed. We have sublingual or buccal, where drug is placed under the tongue, that is sublingual, or between gum and the cheek, that is the buccal route. Okay, so these are the advantages and disadvantages. You can just read through them. Then we have intravenous, is drug injected directly into the bloodstream through the vein. Okay, so this one, it has an immediate action, and it provides 100% bioavailability of the drug. This means that most drugs taken through intravenous route are readily available for absorption. And that's the major difference between, or the key thing that actually happen between intravenous drug and most drugs that are taken orally, because they don't experience these first class metabolism, where some enzymes break down the drugs, or there's some interactions that actually lead to the drugs to be less available. All right, but in intravenous, it goes straight to the vein and then into the system like into the bloodstream. Okay, so there's nothing that is disrupting it, so they are 100% available. Okay, so we have intramuscular, that is drug injected into the muscle, and a whole lot of them. So I listed them with the advantages, disadvantages, and then some examples of drugs that can be taken through that route. Okay, so let's look at the mechanism of drug transport. So how are these drugs transported in the body, or how are the movement in the body system? Transport across cell membrane, or let's giving a drug is given intravenously, they must cross several semi-permeable cell membranes before it reaches the systemic circulation, which I just explained why most drugs given intravenously are 100% bioavailable for use, why other drugs that is given in other routes may not be 100% bioavailable. Okay, it's because they have to pass a lot of membranes, semi-permeable membranes. As they pass through the membranes, there may be degradation by enzymes, or there may be like interactions that will limit the absorption rate, all right? So cell membranes, they are biological barriers that selectively inhibit passage of drug molecules. So the membranes are composed primarily of a bimolecular lipid matrix, which determines the membrane permeability characteristics. So there are three different ways that drugs may cross membranes. So they may cross the cell membrane through passive diffusion. And what is passive diffusion? So the drug will diffuse across a membrane from a region of high concentration to a region of lower concentration. So what this is talking about, you know, the basic definition of a diffusion, movement of a molecule from a region of higher concentration to a region of lower concentration. So what this means is that, you know, when drug is being administered into the body, let's say a drug that you just swallow a drug. So the first thing is it goes through the small intestine, like through the gastrointestinal tract, and then by then it is more concentrated there. So by virtue of this passive diffusion, from that lower concentration, it will diffuse into a low concentration site. That's like example the bloodstream, okay, until equilibrium is reached. So diffusion rate is directly proportional to the gradient, but also depends on the molecule's lipid solubility, that is if it's a lipid soluble drugs or not, on the size, also on the degree of ionization, and then the area of absorptive surface. So these are different factors that can affect how a drug can be diffused in the cell membrane. Okay, most drugs are weak organic acid or bases existing in unionized and ionized forms in an aqueous environment. So the unionized form is usually lipid soluble, that is lipophilic. Okay, that means they're attracted to a lipid element. Okay, and then they diffuse readily across the membrane. So the ionized form has low lipid solubility but high water solubility, that is the hydrophilic, and high electrical resistance, and thus cannot penetrate cell membranes easily. So what this is trying to explain is that the cell membranes are majorly lipophilic. Okay, they are they are majorly lipophilic. Okay, so they always attract all those ones that are lipid soluble, all those drugs that are lipid soluble, that is, they usually attract them, all right? But those ones that are hydrophilic, that is more water soluble, uh, pass they are more resistant, or they pass and they cannot penetrate through the cell membranes easily. Okay, so we have the second method of drug transport, which is facilitated passive diffusion. So this requires binding between drug or molecule with a specific membrane embedded channel or carrier proteins. So is still type of passive diffusion, but this is requiring um, another proteins or a carrier protein or a transporter that will help in transportation of this drug. Okay, so the theory behind this is that a carrier molecule in the membrane combines reversibly with the substrate, that is a drug molecule outside the stem membrane, and the carrier substance and the carrier surface complex diffuses rapidly across the cell membrane. Okay, It diffuses rapidly across the cell membrane, releasing the substrate at the interior surface. In such cases, the membrane transports only substrate with a relatively specific molecular configuration, and then the availability of carriers limit the process. So the process does not require energy expenditure, and the transport against a concentration gradient cannot occur. So we have example like the glucose transporters. So what this trying to explain is that sometimes even when a drug molecule, they cannot readily enter the cell membrane. There's some carrier proteins that will be found on cell membrane that will help in transporting this molecule. They will bind to them and form a complex. Okay, so when they bind to these drugs and form a complex, they will easily, okay, diffuse through the cell membranes. Okay, just like when you reach let's take for instance when someone wants to cross over to somewhere, maybe to a gate or across the road, and then there's no help, but there's some people there that help in crossing people across the road. So when they help you, like when they maybe carry you or something across the road, it's just like they are carriers that help you to cross the road that you cannot. So that's what this facilitated passive diffusion is talking about. We're saying there must be really this like there must be a kind of specificity that must be involved before a carrier protein can be um, used in transporting of the drug molecules. So another form of mechanism of transport is called active transport. So this active transport is a selective process that requires structurally specific transporter to transport drugs of a certain conformation. So it requires energy expenditure because most times it transports these molecules against their concentration gradient. It can transport from a region of low concentration to a region of higher concentration. That's unlike in diffusion that there must be a region of higher concentration to a region of low concentration. But in active transport, it transports like it requires energy in form of ATP so that it can actually move molecule across the membrane against the concentration gradient, all right? From a low concentration to a high concentration. It is also a saturable process. So these drugs are usually absorbed from specific sites in the small intestine. Example of this active transport, we have oligopeptides importer, like peptide, which facilitate the entry of drugs like the beta-lactam antibody. All right. So what this trying to explain is that sometimes some drugs are being transported by a specific transporters, right? A specific transporter that can actually maneuver the whole process and transport this drug. And because it requires energy expenditure, like in form of ATP, it can actually work against the concentration gradient instead of from the normal flow of higher concentration to lower concentration. It can transport from a low concentration to a high concentration. Okay, so these are the three mechanisms of drug transport. We have the passive diffusion, we have the facilitated passive diffusion, then we have the active transport, which requires energy expenditure. But the previous two doesn't require energy expenditure because they are just flowing from a normal process diffusion, high concentrated to lower concentration. All right. So we have another one, bioavailability of drugs. So these drugs that are being administered, how readily are they available for use by the body? Okay. So bioavailability refers to the extent and rate at which the active moiety, that is this drug or the metabolite, enters the systemic circulation, thereby assessing the site of action. All right. So it describes the rate and then the concentration at which the administered drug reaches the circulation intact. There's a proportion of administered drug that are available to produce pharmacological response. So bioavailability, just like the name, is the drugs that are being administered in the body, how many of them are available for um to be used by the body or to be used to cure that particular disease or infection. All right. So we have different factors that affect bioavailability when they are administered orally. Why is being considered orally? Because I mentioned that intravenous drugs have 100% bioavailability because they go straight to the bloodstream, so they're readily available for the body. But the ones that are administered orally, there are different factors that may affect the bioavailability. That's why they are not 100% available for the body to use. Number one is the physical chemical properties of the drug. That's the makeup of the drug. What are these drug made up of? Okay. Or how are they made? We also have the composition of the drug in the lumen. That's how the drug are being metabolized in the stomach or in the GIT. Okay, we have pH and perfusion of the small intestine. All right, we have the surface and time available for absorption. We also have competing reactions in the lumen, for example, of the food with drug. You know, some food, when you eat some food, it can help to facilitate drug metabolism or it can delay drug metabolism. Okay. We also have hepatic first pass effect, which I explained is it majorly happens in the liver where the drug are being metabolized or they are being and some enzyme act on the drugs and it reduces their bioavailability. So these are the different factors that can affect um drug bioavailability, especially when it is administered orally. All right. So let's look at different types of bioavailability. We have absolute bioavailability and then relative bioavailability. So when something is absolute, it means like 100% of the substance are available to reach the bloodstream, okay, which can be achieved through only intravenous means. So a drug given by the intravenous route will have an absolute bioavailability of 1. So it can be represented as F, that F is equals to 1 or 100% bioavailable. But when it comes to relative bioavailability, it's the amount of substance that reaches the bloodstream through other means of administration, like oral or sublingual routes. So it's used to compare two different extravascular routes of drug administration. So drugs given by other routes, their bioavailability is always less than 1. You know, the absolute is equals to 1. So any other one that is given by other routes is always less than 1 because many times they are not 100% available. So that's why it is um, less than 1. Okay. So what are the causes of low bioavailability of some drugs? So we have some physiological factors that may affect the absorption and bioavailability of the drug taken orally. So we have, like, for example, how long the stomach takes to empty the substance in it. Okay. We also have acidity or pH of the stomach. We also have drug movement through the digestive tract can affect the bioavailability. Person's age, sex, level of physical activity, and then the level of stress can affect bioavailability. For example, you know, in an elderly person, when the person takes drugs, the rate at which the system or the different cells act on the drugs can be different from someone that is very young and active and fragile, all right? Then the drugs may diffuse or absorb faster than someone that is already elderly. So some food, example, high fiber foods and calcium supplements may bind with a drug and prevent it from being absorbed. Okay, so this is talking of food factor. All right. So we have some digestive disorders, example laxatives and diarrhea, which may speed up the passage of substance to the digestive tract and may reduce drug absorption. When someone is battling with diarrhea and maybe the person takes drugs, it can also this can speed up the passage of the substance through the digestive tract. All right. So we also have surgical removal of some parts of the digestive tract, such as the stomach or the colon, may reduce or affect drug absorption. So when there's no essential digestive part of the digestive tract, it can reduce or disrupt drug absorption in the body. So we have another key term, bioequivalence. It indicates that the drug products, when given to the same patient, the same dose, okay, the same dose regimen results in equivalent concentration of drug in plasma and tissue. So it's not to explain that two drugs are said to be bioequivalent if they exhibit the same bioavailability when administered in equal dose. Excuse me. So when two drugs are said to be bioequivalent, it means that they have the same bioavailability when they are administered in equal doses and at the same maybe environments or in other conditions that are required. They are said to be bioequivalent. We're going to be knowing the application of these bioequivalents, all right? We also have what we call the therapeutic equivalent. It indicates that drug products, when given to the same patient in the same dose regimen, have the same therapeutic adverse effects. So drugs that are said to be bioequivalent are also expected to be therapeutically equivalent. So if they are available at the same rate and at the same ratio, they also tend to produce the same effects. Okay, that's therapeutic equivalent. So what are the characteristics or the usefulness of this bioequivalence? Can be used to provide useful information about the dosage or dosage regimen of a given drug and performance of a drug formulation compared to other formulations. So the major application, the major uses of this bioequivalence is that two drugs can be used for the same thing, or if one is not available, they can use the other since they have the same bioavailability and then therapeutic effects. All right, so I'm going to be showing you some drugs that are bioequivalent in the next slide. So this bioequivalence is also quoted as percent, majorly measured in percentage or in decimal, and it has no unit. Intravenous drug are also 100% bioavailable, while non-IV not 100%. It ranges from 0 to 100%. So these are some drugs that are said to be bioequivalent. We have some Tylenol, which is a brand name, then the generic name like paracetamol tablet. Okay, the active ingredient found in these two bioequivalent drugs is acetaminophen, okay, or paracetamol. All right, so these are different drugs that are bioequivalent and then some of the active ingredients that are found in them. We also have this Ventolin inhaler. We also have another one like salbutamol inhaler. They have the same bioavailability and they produce the same therapeutic effects when given in the same dose or in the right condition to the same patient. So they can be used in exchange or when one is not available, another one can be used. All right. So these are the different drugs that are bioequivalent. So let's look at what is called the half-life of a drug. Half-life of a drug is the time taken, okay, for the amount of drug's active substance in your body to reduce by half, just like the name. So when you take drug, the time taken for it, that is for the drug to be maybe administered, absorbed, and then distributed in the body. That is the time taken for it the administered drug to be half is called the half-life of a drug. So it depends on how the body processes and gets rid of the drug. So it can vary from a few hours to few days or sometimes weeks for a particular drug to reach its half-life. So it is the time it takes for the concentration of the drug in the blood and the plasma to reduce by half. So after one half-life, the amount of drug remaining in the body is 50%, just like it is majorly assumed that drug administered is 100%, okay? So after half-life is 50%, after two half-life is 25%, after four half-life, the amount of drug is 6.2 um 25%. So and is considered to be negligible regarding its therapeutic effect. So what is the importance of studying the drug half-life or knowing the drug about the drug half-life? So it helps to check how quickly a drug is removed from the plasma by metabolism or excretion. All right. So it actually helps to know if how fast a drug is being removed from the body. It also helps to determine how long a drug stays in the body. So what the major thing is also helps to know when steady state is reached during repeated dosing. So this half-life, it helps us to know, okay, how frequent someone should take the drug. If a drug actually stays in the body for a long time, it means that the the dosing interval should not be regular. But if it has a short half-life, that means the dosing should be more frequent. Okay, so just like the last important, it indicates how frequently a drug should be taken. That's the dosing interval. Example, drugs with short half-life needs to be taken more frequently than drugs with longer half-life should be taken less frequently. Okay, so the half-life helps in dosing interval of a drug. So the formula for calculating half-life is 0.693 times the volume of distribution all over the clearance, right? Where V is the volume of distribution of drugs and the steady state, and then C is the clearance, how the drug is being cleared from the body, right? So we have that's it about the half-life of a drug. I hope you are still following at this point. All right. So if at any point you're not getting or you are not really following what I am saying, you can drop your question in the comment section. All right. And I'll get to answer them. So let's look at what is called the therapeutic window. Therapeutic window is a range of doses that produces therapeutic response without causing any significant adverse effect in patients. So it is a range of drug concentration in the blood that gives effective treatment without causing toxicity. All right. So this therapeutic window, I think I showed us a graph in the first slide I was trying to explain that when a drug is being administered in the body, if the required dose is not reached, that means that drug will be less effective. But if the dose is maybe there's a higher or overuse of the drugs, there's higher doses, that means the drugs will have possibility of eliciting toxin or being toxic, all right? But this therapeutic window is talking about um that range that a drug must be in order to be safe and be effective. Do you understand? So just think of it as a safe zone of a drug. That is a drug that when someone takes it, okay, that means the person is safe. There's no underdose or overdose. I think that explains it better. So, for example, we have phenytoin. Therapeutic window is 10 to 20 micrograms per milliliter. All right, so below the window is less than 10, meaning that the drug will be ineffective or not enough. All right, while within the window, which is 10 to 20 milligrams, the drug will be effective and safe. But if you give the drug above the therapeutic window, it means that the drug will be toxic. That is, there will be too much of drug in the body. So the therapeutic index, now, I think I'm still going to be explaining it in the next slide. So the therapeutic index is a numerical value that compares a drug's toxic dose to its effective. So it's just like a ratio of the toxic effect and then the effective dose. Okay, so it describes a relationship between the dose of a drug that causes lethal or toxic effect with the dose that causes therapeutic effect. So it can also be called therapeutic ratio, right? So the formula for calculating it is the toxic dose or the lethal dose all over the effective dose in 50% of the population. So this is the formula for calculating the therapeutic index. So it's a ratio between the lethal or the toxic effect all over the effective dose in a 50% of population. All right. So okay, this is just the example of what I was trying to explain, that when we have a high therapeutic index, it means that the drug is a safer drug that has a wider margin of safety. Example with penicillin and NSAIDs. But when a drug has a low therapeutic index, it means that it has a narrow safety margin or is a kind of a riskier drug. We have some example of this drug. We have the digoxin, we have the warfarin, and then we have the lithium. So the wider the range of a or the wider the margin of a therapeutic index, the more safe the drugs will be. You know, these NSA drugs are those drugs like a thing that's being used as analgesic drug, all right? So they have a wide range of safety. That's why you see someone that can take ibuprofen like every day, even from over-the-counter medicine, and the person will still be fine because they have a wide range margin of safety due to the high therapeutic index, right? So this is a graph that is just trying to show us that's been plotted against 50% of the population, that's the dose, and then against the dose. Okay, so we have the drug acted against the therapeutic index, which have when you actually give a drug, the less one when the drug does not elicit any effect, that the drug will not be effective. But when it is within the therapeutic index, that means the drug is safe. All right. But if it's above the therapeutic, it means is now passing this red line that is now have the toxic effects. That's when it's now said to be what? It has a very narrow safety margin and tend to produce a toxin. All right. So we have another term which is a steady state concentration, denoted as P underscore SF. All right. So this steady state concentration is defined at the time when the concentration remains stable or consistent when the drug is given repeatedly or continuously. That's for intravenous infusion. So the time to reach steady state is a function of the half-life, and is achieved when the rate of the drug entering the systemic circulation equals the rate of drug elimination. Okay, so the steady state concentration is trying to explain that, okay, at some point when maybe you are giving you're giving someone drugs repeatedly at different intervals or different time, there will be a time when the rate of the drug entering the body will also be equal to the rate of the drug that is leaving the body due to elimination or excretion, right? And that's when we have a steady state concentration. So for most drugs, the steady state concentration is reached in approximately five half-lives. All right. The time to reach steady state is independent of dose size, the dosing interval, or the number of doses. So the shorter the half-life, the more rapidly the steady state is reached, and vice versa. Because most drugs that have a short half-life, it means that the frequency of giving the dose will be increased, all right? Okay, so it will be easier for you to reach this steady state concentration. So what's the benefit of this steady or knowing this steady state concentration? It helps in dosing design, helps the clinicians or the doctor to decide how often and how much of a drug to give. It also helps to avoid toxicity or underdosing, ensures that the drugs level are within the therapeutic window, all right? We also help to monitor drug therapy, especially for drugs with narrow therapeutic index, which are liable to cause toxins, all right? Then we also help to predict response, like in plasma concentration and steady state often correlate with effects. So it helps to predict the response of the drugs. So let's go back to the next pharmacokinetic process. So we have been discussing about absorption and everything in between. So we are now going over to the next one, which is drug distribution. Remember, we are discussing the ADME, which is absorption, D for distribution, M for metabolism, and then E for excretion or elimination. So we are in the second one, which is drug distribution. So drug distribution describes the reversible transfer of a drug from one location to another, just like the name distribution of drug to the different cells or the different tissues that actually need these drugs, all right? So after a drug enters the systemic circulation, it is distributed to the body tissues. So after the drug has entered the tissues, they are distributed to intestinal fluid. So, drug distribution to the intestinal fluid is being determined primarily by perfusion. For polyperfused tissues, like for the ones that are less permeable, example, the muscles or the fat, distribution is very slow, especially if the tissue has a high affinity for the drug. That means the tissue will bind to the drug and it will not be easy for the drug to easily penetrate that particular tissue. which will actually disrupt the distribution of that drug. So let's look at the factors that can determine the pattern of distribution. We have tissular delivery of drugs by blood. Also have the ability of the drug to cross membranes. We have the binding of drug with blood and tissue components. Like just will say, if the drug have a high affinity, or if the tissue has a high affinity for the drug, then the tissue will bind to the drug and to affect the distribution. We also have its positioning between water and fats, and then its ability to undergo active transport through cell membranes, for example, the P glycoproteins. We've discussed of what active transport means and how the carrier proteins can actually carry this drug against the gradients across the cell membrane. So it's also a factor that determines the pattern of distribution. Let's look at the volume of distribution, which is the theoretical volume of liquid into which the total drug administered will have to be diluted to produce the concentration in the plasma. So if what this volume of distribution is actually talking about is when a drug is being administered in the body, all right? So the drug administered, it has to be absorbed in the body in the sense that it will then circulate to the blood that's in the plasma, all right? So the volume of distribution is being calculated to know the amount of drug that have actually reached or the concentration of this drug in the plasma. All right. So it has nothing to do with the actual volume of the body or its fluid compartment, but rather involve the distribution of the drug within the body. Exactly. So for a drug that is highly tissue bound, very little drug remains in the circulation. Thus, plasma concentration is low and then the volume of distribution is high. Okay. So this is just trying to explain that when it comes to volume of distribution, it's actually talking of distribution of blood in the body and not talking of the fluid content or the volume of fluid in the body, right? Volume of other fluids in the body. It's talking of drugs, volume of drug distribution in the body. So it's calculated as the ratio of those present in the body and its plasma concentration. So that is the dose of drug concentration in the body and then the dose of its plasma concentration, right? So let's say, for example, um, a patient is given 500 milligram of a drug, and then the plasma concentration is 5 milligram per liter. So calculate the volume of distribution. Say that is dose of the drug in the body, which is 500 milligram, over the concentration, that's the plasma concentration, that is 5 milligram. It's giving us a volume of distribution of 100 liter. All right. So this is much larger than the total body weight, which is approximately 42 liter, meaning that the drug distributes heavily into the tissues on the fats. Okay. So it just means that the blood um or the drug actually distributes very well in the body when you have a 100 liter of volume of distribution. So what's the clinical uses or advantages of this drug distribution? It reflects the size of the distribution space, thereby giving you an idea of the localization of the drug in the target organ. So with a large volume of distribution, you will need a higher dose to load, while a low volume of distribution need a lower dose to load. Okay, so it also helps to determine how much drug to give to reach the desired plasma concentration. Then it also helps to predict drug concentration. So these are just the different benefits of this volume of distribution. Okay, it helps to determine how much drug to give to reach the plasma concentration. It also helps to predict drug concentration. All right, so let's go back to the next pharmacokinetic process, which is drug metabolism. So discuss on distribution of drugs in the body, talk about absorption of drugs. So let's look at how these drugs have been broken down through metabolism or biotransformation. So what is metabolism or biotransformation? It's a process by which drugs are converted into more polar forms through a series of enzymatic reactions. So this serves to increase the renal elimination of the drugs. So the major aim of drug metabolism is to convert these drugs into a more soluble forms, that is the water soluble forms, in order for these drugs to be easily eliminated or removed from the body. Okay? Because you know that these drugs cannot, after they have produced a therapeutic effect, you cannot leave them to stay in the body for a long time. So there's a way that the body actually gets rid of them. That's the excess ones or the ones that have actually done what it's supposed to do. Okay. So the metabolite might still have potential biological activity or might have toxic properties. So an inactive or weakly active substance that have an active metabolite is called a prodrug. Okay. So, excuse me. Where are the different sites of metabolism? Metabolic enzymes are located in many different tissues and usually reflect tissue with a high exposure to xenobiotics. So those tissues, xenobiotics are like foreign substances in the body. It can be a drug, it can be like dust, like any foreign substance, any part of the body that has a lot of xenobiotic. That's where this metabolic or metabolism actually occurs. So this includes tissues in the liver, in the lungs, in the nasal mucosa, eye, and then the gastrointestinal tract. So the main site of biotransformation is the liver. Why? Because of its size, it has a very large size and then a high concentration of these metabolic enzymes. So that's why a lot of the that's why it's a main site for biotransformation of metabolism because of has a very large size and it contains a lot of metabolic enzymes that help to degrade or metabolize this drug, which is a xenobiotic. All right. So drugs can be metabolized in different ways or in different reactions. The case may be you have oxidation, you have reduction, you have hydrolysis, hydration, conjugation, condensation, or isomerization. So whatever the process, the goal of metabolism is to make the drug easier to excrete. The enzymes involved in metabolism are present in many tissues, but generally they are more concentrated in the liver, just like what I've explained above, alright? So let's explain what first pass elimination is. I think I've explained it several times when I was explaining the rate of absorption and the factors. So many xenobiotics are absorbed from the gastrointestinal tract by the liver and they metabolize them, right? This is designed to prevent high levels of orally ingested xenobiotic reaching circulation. However, the first pass metabolism can limit the bioavailability of some drugs. Alternative routes of administration avoid the first pass effect. Notable drugs that experience a first pass effect include imipramine, morphine, diazepam, demerol, cimetidine, and then the lidocaine. So what this first pass effect is trying to in metabolism that occurs in the liver, right? That when a drug is being ingested and it has to pass through these gastrointestinal tract. There are a lot of enzymes, there are a lot of metabolic enzymes will act on these drugs and to reduce the bioavailability to elicit its therapeutic effects. So that's why other routes of administration can be taken, like intravenous, which helps to produce like 100% bioavailability. We also have sublingual, we have the buccal, like a lot of other routes that can help to bypass this um first pass metabolism. All right. Then we also have stages of metabolism. It occurs in two major stages. You have stage one, which introduces or exposes a functional group. They can have the hydroxyl group, the amine group, or the carboxylic group, and they only slightly increases polarity. So these reactions are non-synthetic. Okay, so what this trying to explain is that in the first phase of the metabolism, which involves like three major reactions, we have the hydrolysis, oxidation, and reduction. We just help to introduce another functional group to the drugs to make them more polar or water soluble. That's the major aim. And when they are more polar water soluble, they helps in easy elimination. All right. So many phase one products are not effectively eliminated and may require a second conjugation reaction by phase two enzymes to confirm a highly polar conjugate that can be excreted in the urine. So when after the process of the phase one metabolism, and then some of these drugs are not eliminated, so they have to undergo the second stage of this metabolism, which is the phase two reaction. So this reaction, they are synthetic anabolic reactions that involve conjugation, whereby another molecule is added to the drugs entirely, such as glucuronidation, sulfation, acetylation, methylation, glutathione conjugation, and amino acid conjugation. So these are primarily cytosolic reactions and are much faster than the first one. So what this is talking about is that instead of introducing or exposing a new functional group to the drug in order to make it more polar, here a conjugation, that is not adding of another molecule entirely to the drugs. Okay, so the addition of another molecule to the drugs. So conjugation makes drugs more soluble. So the aim is just to make them more soluble, which can be easily excreted in the kidney. We have one major phase two reaction, which is called glucuronidation. Is the most common phase two reaction. Is the only one that occurs in the liver microsomal enzyme system, and they are excreted, glucona is excreted in bile and eliminated in the urine. So most drugs that are being conjugated with glucuronides are being secreted in the bile and eliminated and also eliminated in the urine. Okay, so these are the different stages of the metabolism. We have the phase one and then the phase two reaction. So let's talk about what a key or a unique enzyme called cytochrome P40 enzyme. What is this cytochrome P40? It's a hemoprotein that plays a key role in the metabolism of drugs and other xenobiotics. Okay, so they are the most important enzyme system of phase one metabolism. The phase one we just explained above. So it's a microsomal superfamily of isoenzymes that catalyze the oxidation of many drugs. Note that we explained that there are three different reactions in phase one. We have hydrolysis, we have oxidation, reduction, as you can see on this slide. So this cytochrome P40, P450, they are the most important enzyme system of phase one metabolism, all right? That which is involved in oxidation of many drugs. So there are about 17 families of this TYP, the cytochrome in humans. And the importance of families that are involved in drug metabolism are the CP1A, cytochrome 1B, and then cytochrome 2AD, and cytochrome 3A. So these are the major ones that are involved in drug metabolism. It's not all drugs that have cytochrome activity. However, the ones that have this cytochrome activity may be inhibitors, inducers, or substrates for a specific cytochrome P enzymatic pathway. They thus alter the metabolism of concurrently administered agents. Okay, so the most common reaction catalyzed by cytochrome P450 is monoxygenase reaction, where that is just like the oxidation, where there is insertion of one atom of oxygen into the aliphatic position of an organic substrate. It's talking about drug now, while the other oxygen atom is reduced to water, making it more polar. So this is like a chemical reaction of the cytochrome P40, where there is insertion of oxygen leading to production of water. Okay, I think this chemical reaction is not there's supposed to be an equal to here. Okay, it's supposed to be an equal to when there's addition of oxygen leading to production of water and then reduction in this NADPH. So don't mind me, there's going to be a plus, an equal to here instead of a plus. So you can actually balance the chemical reaction and then know where you add this equal to, but it should be here. Okay, so this is not correct. There's a little modification to it. So it's supposed to be equal to here. All right. Hope you understand what I'm talking about. So the cytochrome oxidation reaction involves a different cytochrome P oxidation reaction. We have hydroxylation, we have heteroatom, we have oxidative group transfer, we have cleavage of esters, we also have dehydrogenation. So these are the different oxidation reaction that involves the cytochrome enzyme. So we have mechanism of enzymatic process to improve metabolism. So this enzymatic process is talking about that three different mechanisms, talking of enzyme inhibition, enzyme induction, and then auto-induction. All right, we need to be discussing about them, how drugs can actually, like how drugs react to this cytochrome P40 enzyme. Okay, some drugs can inhibit it, some drugs can induce it, and some drugs can also induce it. So let's look at what enzyme inhibition means. So this cytochrome enzyme inhibition can lead to adverse drug reaction due to altered metabolism. This occurs when a drug reduces the activity, something to inhibit. It means that the thing is reducing the activity of this enzyme, okay, or is preventing or is not allowing this enzyme to express himself, okay, which is slow the metabolism of other drugs that rely on this same enzyme. Do you understand what I'm talking about? So that's what enzyme inhibition is, when drug inhibits the activity of the cytochrome P450 enzymes, which slow the metabolism of other drugs that rely on the same enzyme. You know, the major aim or the major application of this cytochrome P450 is to metabolize drugs. And when a drug is metabolized, it helps the drug to be in a more water-soluble form, that is in a polar form, for easy elimination. So when some drugs inactivate or inhibit this cytochrome P activity, it will then prevent the metabolism of other drugs. So there's a consequence to it. It leads in blood concentration of these other drugs, which can lead to toxic effects. Do you understand? A drug that is supposed to be metabolized, that's supposed to be broken down and eliminated in the body, when it is not eliminated, the blood concentration of that drug can increase. Okay, it will just gather there. There's no metabolism going, it can lead to toxicity. Okay, so there are different types of inhibition. We have competitive inhibition, where drugs compete for the same binding site. We also have non-competitive inhibition. Okay, so we have example of this drug inhibition. Example, ketoconazole inhibits cytochrome P3A4, which increases the level of midazolam, um, which increases the level of this midazolam like concentration in the body. Okay, so when this ketoconazole inhibits this cytochrome P40, it means that it will not metabolize. It's supposed to metabolize this midazolam drugs. Okay, so the effect is that ketoconazole, which is a systemic antifungal, inhibit the liver enzyme cytochrome P3A4, which is responsible for metabolizing this midazolam. Okay, so this inhibition leads to increased midazolam concentration in the bloodstream, potentially causing prolonged sedation, respiratory depression, and other serious side effects. Do you understand what I'm saying? This is a very typical example when you give ketoconazole and this midazolam drug together. So this ketoconazole can inhibit the metabolism of this drug, and then this drug will increase in concentration in the bloodstream and cause a serious side effect. So drug inhibition can also be used to increase bioavailability of a drug. For instance, we have drugs for HIV like ritonavir and sequinavir. So this ritonavir inhibits cytochrome P3A. Okay, so they inhibit the enzyme. Okay, so when they inhibit this enzyme, and this enzyme is responsible for the second drug metabolism. The sequinavir is metabolized by cytochrome 3A. So a combination of ritonavir and this, sorry, how to move this up a bit. Okay, So the concentration, a combination of this ritonavir and saponavir is synergistic in HIV. So what this is talking about is sometimes drug inhibition can also be beneficial in as much as in many cases it causes a toxic effect. It can be beneficial in the sense that um, these two HIV drugs, one is inhibiting the cytochrome P3A enzyme, okay, which metabolize a synergistic drug. That is a drug that they work together with. Okay, synergistic means that they work together to produce a therapeutic effect. All right. So when you if these two drugs are not given together, it means that this second drug, tapinava, will be metabolized by the cytochrome P3A, which will reduce the bioavailability of the drug, and then there will not be efficacy. But when the two drugs are given together, the ritonavir will stop the metabolism of the cytochrome, inhibit this enzyme, and then this saponava will not be metabolized, and then they will produce a therapeutic effect. All right. Hope you understand. So let's look at mechanism of enzyme. The second mechanism of enzymatic process, we have enzyme induction. So unlike the enzyme inhibition, which stop or reduce the expression of the cytochrome enzyme, some drugs can enhance the expression of some the CYP enzymes, cytochrome P enzymes. This can be beneficial because induction increases the pool of enzymes available to catalyze specific drug metabolizing reaction. However, other drugs can be metabolized much more rapidly than would be anticipated. This does not cause a toxic effect but results in sub-therapeutic levels of drug. So what it's talking about, instead of inhibiting, some drugs can actually enhance or encourage the expression of these cytochrome P enzymes. So when they encourage expression, it means that they will metabolize this enzyme will be working very well in metabolizing drugs. Okay, the other drugs can be metabolized more rapidly, and this can cause make some drugs to be less available. That is sub-therapeutic level of drugs that make them less available because they are being metabolized very fast by this enzyme. Okay, so for example, where is the rifampicin induces cytochrome P3A4, lowering levels of oral contraceptives, which can risk contraceptive failure. So because this rifampicin induces the drug, so this enzyme induces this enzyme, sorry. So this enzyme will then lead to metabolizing of this oral contraceptives when you take it. It can make this contraceptive to fail, all right, because they will not be easily available because they're really metabolized by this enzyme. Okay, so we also have the third, which is autoinduction. It's a special case of enzyme induction where a drug induces the enzyme that metabolizes enzyme. So this one is not like another drug like rifampicin induces cytochrome 3A4, lowering levels of oral contraceptives. This one is the drug inducing the enzyme itself, like autoinduction, like you doing yourself. I think that's the layman's understanding that can be explained. So this leads to decreased plasma level of the drug over time and may require dose escalation to maintain therapeutic levels. So for example, is kappa mezapine induces cytochrome 3A4, which increases its own metabolism. So this drug will induce the cytochrome 3A4 itself. Okay, it doesn't need like a synergistic drug, like a second drug to induce it. So induce it itself, it can lead to increased metabolism of a drug. And when it increase, there's increased rate of this drug metabolism, it means that it requires dose escalation, like higher doses to maintain the therapeutic level because they have been metabolized very fast by these enzymes. Okay, I hope you understand at this point in time. Let me know if you're following. Please let me know if you're following by liking this our discussion, by liking this video. If you're watching this from YouTube, let me know if you're following by liking this video. Okay, and also asking your questions. So at this point, I think you can just support the channel by subscribing, and then just when you look down, you can see the subscribe button. So you can just support the channel and then everything we are doing here. All right. So also if you are a master student of the National Open University, there's a community or WhatsApp community that I created where you can receive information, updates about what's happening, and everything in between about the public health program, master's program specifically for now. Okay, so I'm going to be linking the community in this video description, so you can easily click on it and join the WhatsApp community. So you getting information, updates, facilitation, and everything from the WhatsApp group. Okay, so if you're interested, you can just click on the link in the description of this video to join. So at this point, I hope you've understood this point. I know it can be kind of complicated, especially when you're hearing all these things for the first time. Be like, what is this person talking about? But don't worry, it just requires gradual assimilation. With times, everything will just get to digest. So everything must not enter now, or maybe at the first glance, but continuous listening or more research. You can do more research, please. Is very, very important. Anything you don't understand, Google is our friend. Make use of Google, make use of any platform or website that can help. You have ChatGPT, like you can ask anything on Google and they will answer you, please. So don't be confused or don't just um anything you don't understand, don't just skip it. You have to understand every detail so they could be following in this pharmacology because they are kind of interlinked each other. So each one leads to the next, each one leads to the next. All right. Well, thank you so much. At this point, you are still listening. Please, you can just do the following activities, support the channel, you can subscribe, you can join the public health community on WhatsApp, you can also click on the notification so that you get to be notified anytime you're watching this video. All right. So at this point, I want you to read up the drug-to-drug interactions. Okay, is another interesting topic on this one. You have the 810 material, it is there, so you could read it up just to get more knowledge on it. Okay, so let's look at advantages of metabolism. We've talking of metabolism for a while now, so let's look at what are the advantage on your own team. I think you can actually list the advantage of metabolism. All right, so maybe you can just not to deceive yourself, you can just close this screen or go back to the last screen and then list some from your head, some advantages of metabolism from everything I've explained. What can you think that how is this how is it even important to metabolize drugs, to break down drugs, to make drugs more polar? Like, it's important. Of course, it's very, very important. Number one, it helps in activation of prodrugs. Prodrugs, they are drugs that are inactive, that are being acted upon or metabolized to expose the active forms. Okay. So some drugs are even given in these prodrug like inactive forms so that when they are being metabolized in the body, they can produce an active one. So they're very, very important. It facilitates excretion. Yes, it's very, very important because when these drugs accumulate in the body, they can um, form toxins, okay? They can lead to very serious side effects. So also lead to decreased toxicity, decreased metabolic inactivation, increased chemical stability, prevent drug accumulation. So these are the usefulness of this metabolism or the biotransformation process. What are the consequences of metabolism? Or what are the things that can result as a result of metabolism? The end product can involve active drugs to inactive metabolites, right? That's the normal range is supposed to go to from inactive drugs to inactive metabolites. For example, the morphine, the chloramphenicol. Metabolism can also lead to active drug to active metabolites. Is one consequence because these active metabolites can sometimes be toxic or can sometimes elicit and a side effect that is not favorable to the host. Okay, example is phenacetin. So another consequence of this metabolism, it can lead to inactive drug to active metabolites like levodopa. So I explained that prodrugs is inactive drugs, where inactive drugs is converted to active metabolites. So these are the different consequences of this metabolism, and is also another thing that you go to look at, especially when you're prescribing a drug to a patient. What is there any risk involved maybe with these drugs? Okay. So let's go back to the last but not the least pharmacokinetic process. I think it's been a long discussion, and I try as much as possible to make it more brief and straight to the point. But there's some things you cannot just escape or skip when you are trying to explain some vital things. Okay, that's why I have to put all things together. They're very, very important. Okay, and the key things to know. So let's look at drug clearance or excretion. Remember, we are discussing the four pharmacokinetics process, which is the short form. Can you remember the short form? Can you tell me the comment section, the short form of this pharmacokinetic process? I'm not going to mention it, but I'm just going to mention the name. We have absorption, we have absorption, we have distribution, we have metabolism, and then the last one, which is the excretion, right? I hope by now you remember the short form. So let's start by why drug elimination is important. Why do we have to remove or get rid of some of the drugs we take? Okay, it's because some drugs remains unchanged in the body. So excretion is very, very important for the termination of the drug's effects because the longer they stay, the more it can be toxic to the body. Excuse me. So the kidneys are the principal organ for excreting water-soluble substances. So there are different routes or different passages for drug elimination in the body. We have the renal clearance, where that involves the kidney. That's where most of the drugs are being um, leave the body through urine, either through uncharged or polar metabolites. So what it's talking about is the drugs passes through different phases or through the kidney process. The kidney helps in removal of a lot of xenobiotics in the body. So the drug passes through the kidney and they can be removed through the urine. All right. So that's the renal clearance. Then we have the biliary excretion is a process where drugs and the metabolite eliminated from the body through the bile. So the bile is a fluid produced by the liver that helps with digestion. So this process is particularly important for drugs that are poorly soluble in water and tend to accumulate in the liver. So most drugs that doesn't live through the kidney processes, they live through the biliary excretion. We also have the pulmonary excretions talking about through the lungs and breath. Some of the drugs, as we breathe, can remove some of the drugs. We're talking of anesthetic drugs here. Okay, that's most of the volatile molecules that can be excreted through gaseous means. They are being removed through pulmonary excretion. So we have through skin, like sweat. Most times when we are sweating, it also helps. Though is a very, let me say, minute way of drug excretion, but it's still an important way. We also have saliva, drug elimination. So we have mammary or milk. So this is talking about the clinical relevance of the effects of a drug is evident when considering breastfeeding a baby, for example. So most times when a mom, as a breastfeeding mom or a lactating mom, is feeding the baby, the drugs can actually pass from the mom to the baby. All right, and this can be beneficial and this can be toxic. For example, we have chloramphenicol can result in bone marrow toxicity and also cause gray baby syndrome, where babies cannot metabolize the drug effectively. When a mom is giving this chloramphenicol drug, it can be toxic to the baby. All right, so there are the different ways that drugs can be eliminated. So let's look at the processes of renal drug excretion. Okay, the processes, we have the that is the ways these drugs are being excreted, especially for the renal is talking about the kidney processes. All right, so I'm trying to check where I'm going to put this. All right, this is better. So let's look at the first one, the glomerular filtration. This glomerular filtration just have a scenario of maybe you are trying to sieve something, sieve. Sieve has a specific size And when maybe something is bigger than that size of the seed, it actually stay afloat. But when something is of a smaller size than the seed, it actually follow through the sieve core. Okay. All right. So drug molecules in plasma are filtered, just like the sieve I tried to explain, into the Bowman's capsule size, into the Bowman capsule based on size and protein binding. So only unbound, that is the free drug molecules, are filtered, while the protein bound drugs, example the albumin band, are not filtered. So, example, we have the gentamicin, a water-soluble unbound drug, is eliminated almost by the glomerular filtration. Just like we explained, these glomerular, they are being filtered based on the size and the protein binding. Most drugs that are not being bound, that is, are free drugs, they are being filtered, okay, and they're being eliminated through this process. But those ones that are protein bound, example, albumin bound, are not filtered, okay. We have another method, another process, active tubular secretion. Here, drugs are actively transported from blood into the tubular fluid by specific transporter protein. It is an energy-dependent process, requires ATP, and then they work for both ionized and non-ionized drugs, and even protein-bound drugs, as transporters can strip drugs from the protein. So this one, just like the active, then remember the active transport I've explained. So it requires a specific transporter and requires energy, okay, in form of ATP. So those ones that are on bound proteins, here is where they are getting filtered because those transporter, they will just strip that particular drug from the bounded protein and they will be get filtered away. Example, penicillin is secretly sorry, penicillin is secreted rapidly by OAT, which is the organic anion transporter. So there are two main systems in active tubular secretion. We have the organic anion transporter. We have the organic cation transporter. This is talking of the positive and then the negative. Sorry, the acidic and then the basic drugs. The anion for the acidic drugs, then the cation for the basic drugs. Like I said, they required a transporter from the anion transporter for acidic drugs, example penicillin, furosemide, or the cation that's for basic drugs like morphine, cimetidine. All right. So this transporter helps um, in um, transporting or removal of the drug that enables its elimination. All right. So that's what active tubular secretion is talking about. Then passive diffusion across tubular epithelium. It occurs mainly in the distal tubule and connecting dots. Here, the lipid-soluble non-ionized drug molecules are diffused back into the tubular fluid, into the bloodstream. So it depends on the drug lipid solubility, urine pH, and then the urine flow rate for it to be eliminated. For example, aspirin, which is a weak acid, is reabsorbed less in alkaline urine. Then alkalizing urine, example with sodium bicarbonate, enhances its secretion during overdose. Do you understand? Like this, just like the passive diffusion we have explained, we just um the use of maybe another substance, okay, touching of another substance here, maybe alkalizing, if you want to eliminate aspirin, which is a weak acid, all right, is reabsorbed less in alkaline urine because it's an acid and there's no that specificity involved. So for you to be able to remove them, you have to alkalize the urine with maybe sodium bicarbonate, which enhances its excretion during overdose. All right, so that's it about the passive diffusion. So let's look on. I hope you understand these processes of renal drug excretion. All right, so let's look at the pharmacokinetic changes in pregnancy and lactation. So this is about a specific changes that occurs or specific things that occurs when a woman is either maybe pregnant or breastfeeding a baby. What are the different pharmacokinetic, as the absorption, distribution, metabolism, and remind me the last one. Oh, elimination. All All right, so the use of drugs in pregnancy is generally complicated because it has a potential for harmful effects on the growing baby or the fetus. So, maybe because of the altered maternal physiology, different hormones playing its role, different changes, changes in the body size, changes in absorption rate, and a lot. So, a lot happening in a woman that is pregnant or lactating, and this can make it very complicated to prescribe drugs when someone is pregnant. You know, most times when one is pregnant, they tell you, please don't take any drugs. Even some drugs, they write it not for pregnant or lactating mothers. All right? Because it's very, very, like I say, it's complicated. Okay, so because experience with many drugs in pregnancy is severely limited, it should be assumed that all drugs are potentially harmful until sufficient data exists to indicate otherwise. So that's just the basic thing. So let's talk about what happened during the absorption process. We're talking about pharmacokinetic changes, right? So let's talk about absorption process. Here, the gastric emptying and small intestinal motility are reduced due to elevation of progesterone, particularly in the third trimester, thus delaying the appearance in the plasma of orally administered drugs and onset of effects of the drug, especially during labor. So this is of little consequence unless rapid drug action is required. Vomiting associated with pregnancy may make oral drug administration impractical. So absorption from intramuscular site is likely to be efficient because tissue perfusion is increased due to vasodilation. So this is talking about the best or the better method of drug administration or absorption in the pregnant woman's body. We're talking of maybe orally administering drugs orally may not really be the best because you know there are a lot of most pregnant women experience nausea and vomiting during pregnancy. So there's a high rate of vomiting the drugs, but absorption from intermuscular site is likely to be efficient because the tissue perfusion due to increased vasodilation in a woman's body. All right, so let's talk about distribution, how these drugs are being distributed in pregnancy. During pregnancy, the blood volume increased by one third with expansion in plasma volume, that is from almost 2.5 to 4 liters at time, being disproportionate to expansion in red cell mass. So the hematocritic force, there's also an increase in body water due to large extravascular volumes and changes in the uterus and breast. Also during pregnancy, the plasma protein concentration falls and there's increased competition for binding site due to competition by endogenous ligands such as increased hormone levels. So these factors alter the total amount of bound drugs and apparent volume of distribution. However, the concentration of free drug usually remain unaltered because a great volume of distribution of free drugs is accompanied by increased clearance of free drug. So what this is talking about is there are a lot of factors that can determine how drug is being distributed in a pregnant woman's body because you know as due to when someone is pregnant, there are a lot of different hormones then which can be competing for different body sites of a drug, and this can limit the drug distribution during pregnancy. Okay, so and also increase in blood volume, increase in yeah, the blood volume, like just like I said, and also the plasma protein concentration falls and increase in competition for binding site. So all this contributes to factors that can affect volume of distribution during pregnancy. All right, so let's look at metabolism. Metabolism of drug by the pregnant liver is increased because due to large enzyme induction, perhaps by raised hormonal levels, because there are a lot of hormones that is being produced. So the metabolism of drug in the liver, you know, the liver actually deals with the metabolic enzymes that helps in metabolizing of all these drugs as the xenobiotics, right? So metabolism is being increased. So liver blood flow does not change, and this may lead to an increased rate of elimination of these drugs, all right? For which enzyme activity rather than liver blood flow is the main determinant of elimination rate, because there's an increased enzyme activity, which is the key determinant of elimination rate. Then there will be increased rates of elimination of drugs. All right, example is theophylline. So that's just about metabolism. Then when it comes to excretion or elimination, excretion of drugs via the kidney increases because of renal plasma flow, almost doubles, and then the glomerular filtration rate increases by 50% during pregnancy. This has been documented for dalzane, lithium, ampicillin, cefalexin, and then gentamicin. So there's rapid loss of drugs that are excreted by kidney. Example, amoxicillin, those of which should be doubled for systemic infections. So when a drug is rapidly metabolized or eliminated, it means that the dose, the consequence of the effect is that the dose should be increased or doubled for systemic infections. Okay, so this is about the different pharmacokinetic changes in pregnancy involving absorption of drugs, distribution of drugs, metabolism of drugs, excretion or elimination of drugs. Can also read more on this. There's a lot of interesting things to know on this particular subtopic, but I just want you to have a general overview of what's talking about. You can research more on it. It's very, very interesting to read. So let's talk about placenta transfer of drugs. How drugs can actually be transferred from placenta to the baby. You know, the placenta is like a connection between the mother and the baby where there's transportation of food, transportation of other vital things. Even drugs can also be transferred, all right? So the placenta is not a perfect barrier to drugs and chemical administered to mother. So thalidomide tragedy showed that placenta was capable of transferring drugs ingested by mother to fetus with potential for great harm. Okay, so this thalidomide tragedy, it occurs long time ago when this thalidomide is a drug that is being prescribed maybe for pregnant women to treat nausea and all those pregnancy symptoms, pregnancy effects, all right? But they noticed that this thalidomide it then causes a great side effect for those children that are born within those periods where their mothers use this particular medicine. It causes them a lot of harm, okay? So like for those time, those children has this long this lifetime defect. Okay, so that's why it's called thalidomide tragedy, where the placenta transferred this drug ingested by the mother to the fetus, and it causes a great harm. That's why the drug was stopped at that time. So on the other hand, placenta transfer of drugs administered to mother has also been used to treat fetal and arrhythmias, congestive heart failure, and other conditions. So it can also be useful in as much as it can be toxic. All right. It can also be useful to treat a baby, a growing baby. All right. Through placenta transfer of drugs, like say it can be used to treat congestive heart failure and other disease conditions. So there's a benefit to it. The only thing is that the drugs that we need to be researched thoroughly before being recommended for a pregnant woman. So know the different effects that these drugs can elicit. All right. So we have factors affecting placental drug transfer and fetal tissue. We have duration of exposure to drug. We have protein binding. We also have the pH difference, lipid solubility, molecular weight of the drug. So most drugs with low molecular weight do not cross the placental membrane, while the drugs with higher molecular weight can easily cross the placental membrane. They also have physical chemical properties of drug, that's the makeup of the drug, how the drug is made, and then the permeability and every other factors that can affect placental drug transfer. All right, so this is it about the placental drug transfer of drugs from mother to child. It can be beneficial, while it can also be harmful. So this has been a long discussion, and at this point, I hope you've learned a lot. And I want you to take the self-assessment exercise. It will help you to assess what you've learned and know if you have actually assimilated what you've learned, what is the importance of drug concentration, advantages of and disadvantages of oral drug administration, explain the 10 therapeutic window and therapeutic index. All this we've treated, What are the different routes of drug administration? Very easy. Define bioavailability and discover the factors affecting drug absorption. Define the following: half-life of a drug, steady state plasma concentration, and then the drug interactions. Okay, so as I hope at this juncture I've done justice to this module one, the basic principles of pharmacokinetics. And if you have done the self-assessment and you are good to go, you've answered the whole question, that means you can actually go on. And on the next topic, we're going to be teaching toxicology and adverse drug reaction. So at this point, I want you to tell me in the comment section if you are really enjoying the class, what you observe. Your feedback is highly needed. Please just give me a feedback in the comment section to actually help. So keep the class flowing, all right? Then also please share this video to someone that you know that need it, or someone you know that is currently studying public health in any school. This can be very helpful provided that this is in their own curriculum, all right? So please, you can share this video. And then I'm saying thank you so much for your attention. Thank you so much for listening and then staying through this discussion class. If you have any question, don't forget to drop in the comment section. And if you want to join our WhatsApp community, and click the link in the description. So see you in the next class. Bye.